Dear all, welcome on behalf of the Heart Failure Policy Network to the Heart Failure Policy Summit, the only dedicated policy event for the heart failure community in Europe. I am Ekaterini Lambrinou. I am a professor of nursing at the Cyprus University of Technology. Thank you for joining us today to the second session of the Heart Failure Policy Summit, which will focus on innovation in heart failure diagnosis and care, exploring promising examples, the policy landscape, and remaining challenges. Before we start, I would like to also welcome Mr. Ed Harding, the Network Director, for a welcome.
Thank you very much, Katerini. Just a quick note of thanks to the sponsors for the summit overall, and therefore this event today. So our appreciation to AstraZeneca, Vifor, Boehringer Ingelheim, and Roche Diagnostics for sponsoring the summit, without which this event mightn't be possible.
Thank you also for organizing everything, Ed. So the goals of these sessions are: how can we reach top-level decision makers and convince them of the value of investing in innovation for heart failure diagnosis and care? What can we learn from each other in implementing innovation and redesigning healthcare service? How can we work together as a community across all sectors to drive innovation? Just to let you know that if you have problems with the video, please refresh the page and it will start again. And if you prefer, you can turn on auto-generated subtitles by clicking on the option bottom right. So we're looking forward to hearing from experts in innovation for cardiovascular diseases and heart failure. Following an overview of the landscape for implementing innovation in cardiology, we will delve into the opportunities for heart failure. We will discuss innovative tools and approaches that could be used to detect heart failure as early as possible in community settings and improve management to prevent hospital admissions. And also the last speaker will provide insights into the opportunity for driving innovation in the EU policy context. And during the roundtable discussion, we will bring some of the speakers back to reflect on their presentations and discuss barriers and enablers to spread innovation across Europe. You may, and please do pose your question in the question and answer box, and we will answer them during the session if possible, or at the end during the discussion with our speakers, or in the community chat on the event platform after the session. We are honored to start this summit with a keynote address to the heart failure community by Mr. Tomislav Sokol, a member of the European Parliament in Croatia. He's committed to addressing cardiovascular diseases as a member of the Heart Group and the Committee on Environment, Public Health and Food Safety. He's also involved in implementing innovation as the rapporteur for the European Health Data Space.
Greetings, everyone. Cardiovascular diseases are the leading cause of death in Europe and are known to be slowing improvements in life expectancy. Heart failure is a major cause of hospitalization, costing billions of euros every year across European countries. If we want to improve healthcare resilience and sustainability, it is key to address cardiovascular diseases such as heart failure. A major way to reduce the burden of heart failure is to prevent hospitalizations by shifting diagnosis and care into the community, moving away from a reactive approach to care and over-reliance on the hospital sector. For this, we need to invest in innovation, data, and e-health that can empower primary and community care professionals to deliver high-quality care. In regards to that, the Commission presented the European Health Data Space proposal to revolutionize healthcare through digitalization. I have been appointed as a rapporteur for the European Health Data Space in the ENVI Committee in the European Parliament. The HDS can also help us fight cardiovascular diseases. It will promote better exchange and access to different types of electronic health data. Not only will this support healthcare delivery, it will also support health research, innovation, policymaking, and regulatory purposes. With EHDS, we will revolutionize European health systems and prepare them for digital future. To conclude, I want to thank the Heart Failure Policy Network for their work to improve the lives of people living with heart failure by raising awareness of unmet needs. You can count on my support in future initiatives and projects. Thank you for your attention, and I wish you a fruitful debate.
We thank Mr. Sokol, and we will now hear from Dr. Jasper Tromp, Assistant Professor at the National University of Singapore and co-author of the recently published World Health Federation's Roadmap for Digital Health in Cardiology. Thank you.
Thank you so much. I'd like to thank the chair and of course the Heart Failure Policy Network for enabling me to speak to you here today. My name is Jasper Tromp. I'm Assistant Professor of Public Health at the National University of Singapore, and I'm the lead author of the Digital Health Roadmap, about which I'm going to talk to you today. Cardiovascular disease is the global killer, claiming more than 18 million lives each year. Cardiology, I think, is unique because it has a history of innovation and medical first. For example, the Apple Watch, which can now automatically detect atrial fibrillation. As a previous speaker indicated, most technologies used to diagnose many cardiovascular diseases are non-invasive, right? So for heart failure, we use echo. And in some cases, it can lend itself to consultations and follow-up via digital means. Particularly in low resource settings, and that's also one of the interest fields of the World Heart Federation, there are major and rapid advances in internet and mobile technology, which have a very tremendous potential to expand the reach of healthcare and reduce the burden of cardiovascular disease. So digital health interventions together, and this is what we determined together in the World Heart Federation Roadmap, have the potential to empower patients and providers by putting more of their care into their own hands and allowing to interact patients, for example, more with healthcare practitioners. They have the potential to improve long-term patient outcomes. They can improve the patient experience by, for example, enabling them to access their own EHR records on distance. But importantly, they have the potential to promote universal health service coverages by enabling patients from both urban and rural areas to more easily access health services and ultimately reducing costs, which will enable us to provide more healthcare services to our patients. So these are some of the examples of digital health solutions that we've highlighted in the roadmap and that you might be familiar with. So of course, and in many low resource settings, text message programs are very common, right? So there are the ones that help you to quit smoking, where giving you reminders, or the ones that can help you to improve your exercise. Of course, you have wearable devices, which are very common also for patients with heart failure. These include activity trackers. The Apple Watch, which I mentioned, can diagnose atrial fibrillation even nowadays, or wearable devices specifically for patients with heart failure that can manage, for example, or measure fluid status or dyspnea. And of course, we have mobile apps, so mHealth solutions that can help patients to give recommendations to improve their lifestyle or to manage their medication. And for healthcare providers, we have electronic decision support tools, which enable recommendations for treatment for patients, or for example, that patients with heart failure should be on all guideline-directed medications. And finally, we have AI decision support tools that can aid to interpret medical imaging data. So the key objectives of the World Heart Federation Roadmap was not only to discuss the potential of these solutions, but also to primarily analyze roadblocks to the implementation of digital health in cardiology, and then together with experts, identify solutions to overcome some of these roadblocks by providing actionable recommendations. Ultimately, these roadmaps are supposed to lead to engagements of people with their national stakeholders for the implementation of digital health at a country level in the form of national roundtables where patients, providers, and policymakers can come together to discuss some of these local barriers and perhaps use some of the solutions that we provided. So the core of the roadmap was a survey performed online across all of the members of the World Heart Federation, which included 227 responses from cardiologists, other physicians, health professionals, and policymakers from 71 countries that you can see highlighted in the map here on the right. So the survey asked about the availability, acceptability, affordability, and accessibility of some of these technologies listed here, and ultimately found that despite the promise of these technologies, unfortunately, even in high resource settings, they were often either unavailable, had poor acceptability, or were unaffordable. And that was due to various roadblocks that were indicated in the survey, which I'm going to discuss in the next few slides. So these roadblocks we've clustered according to these 4 blocks that you see here, namely those that are present at the health system. So these could be lack of national guidelines or strategies, the health workforce, right? Poor health literacy or digital literacy by healthcare practitioners like doctors or nurses. They could be at the level of the intervention. So the technology could not be interoperable with different healthcare systems, or there could be poor usability and design, increasing the workload for healthcare practitioners. And then finally, of course, and importantly, the patient level. And again, here, very similar to the provider, we found that poor digital literacy and lack of user and context-specific adaptations were important roadblocks. I'm just going to highlight some of them here, and for the sake of time, I'm not going to go into too much depth for each individual ones, but just at the leadership and governance level, we found that one of the major roadblocks was a lack of clear monitoring and evaluation standards. So digital health interventions are unique. They are developed rather quickly, deployed easily, but unfortunately, in a lot of cases, they are not prospectively evaluated like we do with drug trials. And lack of national standards make that there is also usually no need, at least by the providers of digital health solutions, to rigorously evaluate them locally. Lack of national guidelines on data security and access is maybe not in Europe, because we have very strong regulations in Europe, but in a lot of other countries remains an important barrier. An example I can give you from Bangladesh, where there is very poor national guidelines on data security and access, which is a roadblock for doctors to actually use telehealth because they're worried that they might be breaking some other laws that they're unaware of. So the laws are not explicit or specific enough. Then finally, there's also often a lack of regulatory standards, particularly health technology assessment. So what is the bang for your buck that you get for these digital health interventions, which is often poorly defined in local standards? One of the key issues, and I think this is universal, was lack of reimbursement pathways. I work and live in Singapore. Here, we only recently started reimbursing telehealth, but we're actually rolling that back again after the pandemic. Many of the other apps are poorly reimbursed. Even the ones that we use in hospital decision support tools have difficulty finding reimbursement pathways, which remains a clear issue. And then I think another one is the lack of contextualization. So we need apps that integrate well with the local healthcare system and address local barriers. So in other words, if we have apps or solutions that do not integrate with your electronic health record system, they will add more workload for physicians, which will ultimately lead to them not being used. And the other one is that we want to have apps that are available both in on and offline mode. Not all countries and urban and rural areas have equal access to internet. So we need apps that are able to function in both situations. Finally, and I'm just going to touch upon here for the health workforce and patients, we found that in both cases, there was often a poor digital literacy, especially among the elderly. And as you know, heart failure patients are often older, so poor digital literacy is a challenge. And the same goes for some of our cardiologists who struggle with some of these new solutions. So we really need to combine some of these interventions with education to improve effectiveness. Just to give you an example of how you can sort of deploy this roadmap, and this is a solution that I've worked on in my own practice, where we use deep learning algorithms to automatically annotate echocardiograms, which you use to diagnose patients with heart failure. An example of a deep learning algorithm, so machine learning algorithm-based annotation, you can see here on the right. And using these annotations, we can automatically quantify cardiac function to diagnose those with versus without heart failure. But the key issue is here in the deployment of this technology, we made sure it was available in an offline mode and in a cloud-based solution based on local data security standards. But also the app itself was designed keeping cardiologists in mind. And just to briefly touch upon, we're gonna use this in Tunisia, where we're combining this with a point-of-care device, where we're enabling nurses in particular to diagnose heart failure at a patient's home. And in Tunisia particularly, we have a lack of cardiologists, just to illustrate how potentially disruptive this type of technology can be. So just to summarize, we think based on the roadmap, we've seen that digital health solutions can be extremely disruptive for cardiovascular and heart failure clinical care. We've provided some practical solutions for at the health system patient level barriers, as well as for healthcare providers. And hopefully these solutions can be adapted to a heart failure specific context. And with that, I'd like to thank you for your attention.
Thank you, Dr. Trump, for this innovative solution that you just showed. I'm so jealous, especially when you're showing IT solutions that nurses can use. And hopefully we can discuss this later on. And I am moving on to the next speaker, Dr. Matthew Kahn, to explore the case for heart failure screening. He's a consultant cardiologist at the Liverpool Heart and Chest Hospital, and he's involved in the establishment of a heart failure primary care service. The floor is yours.
Well, thanks very much for inviting me to talk here today. It's a real honor, so thank you to the Heart Failure Policy Network. I'm delighted to talk about the case for screening in heart failure, and I'm going to be focusing in particular on our experience with the primary care heart failure service. So we all know where we normally see our heart failure patients. Generally, we see them in primary care, in general cardiology clinics, general medical clinics, heart failure specialist clinics. There can be inpatients, whether they be on inpatient cardiology wards or general medical wards. But is this just the tip of the iceberg? And what about the patients that we don't know about? What about their needs? And I've become increasingly aware of significant numbers of patients that are either underdiagnosed and therefore untreated in the community. So these might be patients who are symptomatic of heart failure in the community, and they just put up with their symptoms and don't seek the care and attention of their primary care physician. They're potentially patients that have been diagnosed with heart failure historically, discharged, and for the last 10, 15 years haven't had access to more modern therapies. And so we teamed up with industry, Medtronic and Inspira Health, to come up with a primary care heart failure service. And the idea was to identify this missed cohort of patients in the community and try and offer interventions to try and avoid a future admission to hospital with a decompensation. So before I talk about that, I'd just like to talk a bit more about the hidden costs of late diagnosis. We all know that heart failure is misdiagnosed, and a report by Pumping Marvelous, which surveyed over 600 patients, had some really interesting findings. So they found that over a third of the patients surveyed were given the wrong diagnosis by a medical professional. Women were almost twice as likely to be misdiagnosed than men, and over 40% of respondents aged under 45 received an incorrect diagnosis. The sorts of diagnoses they'd get would be asthma, anxiety or depression, or acid reflux. So we know these patients, this cohort, are difficult to diagnose and are therefore underdiagnosed and undertreated quite frequently. Where are they diagnosed? Well, only 7% of the patients surveyed were diagnosed in primary care. Over a third were diagnosed in hospital after a GP referral, and close to 40% were diagnosed by a cardiologist or heart failure specialist after they were admitted via A&E. The survey also looked at the use of BNP in primary care, and despite being available for use in primary care, less than a third of patients said their GP had ordered a blood test to test for heart failure, and of those who were tested, 3/4 were men and only 25% were women. So what does all this translate to? Well, we know that there are around 920,000 people in the UK living with heart failure, and of those, roughly 340,000 aren't on GP registers. So a significant proportion of these patients haven't been given appropriate diagnoses. They will therefore not be having access to heart failure teams. They won't be being treated properly. Of course, what does that mean long term? These patients potentially will have a poor prognosis, significant costs to the NHS, poor outcomes in terms of symptom progression and mortality, and of course, poorer quality of life. So we wanted to look at this in a slightly different way, and we designed something called the primary care heart failure service. And as I said, this was a method of trying to access this lost cohort or missed cohort of patients in the community. It was a consultant-led cardiology service, a specialist resource working within GP practices, and it allowed cardiologists within secondary and tertiary care to support GPs in primary care in the delivery of optimal therapy for heart failure patients. And the process has 5 phases. So phase 1 was system interrogation. And the Innsbruck Health ran bespoke heart failure queries on the primary care clinical system. So in particular, we'd look for patients coded as having either both heart failure and LVSD, or patients with heart failure or LVSD. We'd look for patients that may be on drugs that might imply a diagnosis, a historic diagnosis of heart failure, so beta blockers, ACE inhibitors, ARBs, MRAs, etc. We'd look for codes that correspond to things like cardiomyopathy, cardiomegaly, hypertrophy, previous myocardial infarction, and again, we'd look for raised BNP results. The second phase consisted of patient medical records reviews. This was a comprehensive clinical audit of medical records, and it looked for evidence of heart failure like previous investigations, so echoes, cardiac MRIs, hospital admissions, cardiology letters. The first audit assessed the practice LVSD prevalence against NICE guidelines, and it focused on patients with an ejection fraction of less than 35%. So we wanted to identify those patients that were really high risk. The second audit assessed patients who have terms in the medical records which could lead to a diagnosis of heart failure. So that improved registry accuracy by highlighting potential coding issues, and it also audited patient care against best practice guidelines. The third phase consisted of patient invitations. So the consultant cardiologist virtually reviews the auditor's notes to make sure appropriate patients are being invited for either a telephone or a face-to-face consultation. And then the patients were invited to come to their local GP practice and see a heart failure specialist. And that was, of course, phase 4, which was the consultant reviews. So these are specialist-led clinics within the GP, within the patient's own GP practice. They all had an ECG either performed prior to their consultation or during the consultation. It was a one-to-one clinical session, and we often had either a GP sat in with us or a practice nurse or a pharmacist. And in fact, one of the legacies of this project was that of education. It was a fantastic opportunity for us as heart failure specialists to upskill our primary care colleagues, and indeed a learning opportunity for us as heart failure specialists to see how things are best performed in primary care. So the consultation obviously allowed heart failure optimization and indeed the management of high-risk heart failure patients. Often the patients could be managed appropriately in that consultation and nothing further needed to be done, but there was often a need for more tests, and so they were referred to specialist heart failure clinics. And that leads us on to phase 5, which was patient follow-up. So these patients were then reviewed in either secondary or tertiary care by specialist heart failure device teams. The management was further optimized, so that could be medical optimization or indeed device therapy, and at times referral on to advanced heart failure centers as well. The patients were all audited at 3, 6, 9, and 12 months to make sure the treatment pathway was appropriate and to make sure all clinical actions were completed. So this just shows the spread of the PCHF service. I did the first clinic in North Manchester at a local GP practice in quite a deprived area of Manchester. And really it's spread throughout the country. So we can see a list of hospitals there that have cardiologists participating in it at the moment. And we're looking to expand further with the service next year. So I'm just going to briefly talk to you about our experience with 231 GP practices, and that corresponds to 4% of the total population in England. So that involved 1,504 cardiologist reviews. Of those patients seen, 24% were suitable for complex device therapy. So that means that almost a quarter of the patients that we ended up seeing had an ejection fraction less than 35%, and this sort of discussion hadn't been had with those patients at that point. Close to 50% of the patients needed medical optimization, and we all know how important getting tablets on board is. So 50% of the patients there weren't properly optimized. And we also found a 71% increase in LVSD coding, implying a significant undercoding problem. We also looked at socioeconomic deprivation and found a correlation between device candidates and levels of socioeconomic deprivation, with an increased numbers of patients requiring a complex device found in more deprived areas. A similar pattern was found in terms of medical optimization, with increased numbers of patients requiring medical optimization found in areas of higher deprivation. I'm delighted that our work was accepted by the European Heart Journal. We had authors from across the country, including Medtronic and Inspira Health as well. So from a practice population of around 100,000, we'd expect to find the following results, if you like. So we'd expect to see around 60 patients identified for cardiologist review. Close to 400 patients would be for clinical coding review. A number of patients would then be identified for medical optimization and indeed consideration of complex devices. So what are the benefits of the PCHF approach? Well, this service model enables the identification of a high-risk heart failure cohort in the community that isn't necessarily known about, and it facilitates optimal management to improve health outcomes and potentially reduce the chances of future admissions. It increases the numbers of patients referred into specialist centres for consideration of advanced technology like complex devices and further medical optimization. It makes sure practices are compliant with NICE guidelines. It's a consultant-led service in the community, and the patients that we see gave really good feedback. They enjoyed their local cardiologists seeing them in their GP practice. It increases local knowledge of evidence-based strategies for managing heart failure. And one of the big pluses was that it allowed greater engagement between local heart failure teams and primary care. And that's, of course, vital for optimizing heart failure care for our patients. So back to the first question we asked on the first slide, is heart failure suitable for screening? And this insightful editorial, Professor Lund looked at this specifically. So I've just put up this title from the paper, and it looks at the Wilson screening criteria and how that applies to heart failure. And there are a number of sort of criteria that we'd look at. So firstly, is it important? Well, heart failure is common and deadly, so absolutely it's important. Is heart failure treatable? We all know that there are extensive medical therapies, device therapies, more therapies for HFpEF as well, so absolutely it's treatable. Is screening and treatment available? Well, it's not readily available at the moment, but hopefully I've just demonstrated that it can be used using medical records and diagnostic codes. Does it have a latent phase? Well, heart failure can be asymptomatic. And again, I've shown that it can be undiagnosed, and that is specifically important in the community as well. Can it be tested for? Of course, it can be tested for echoes, BNP, and other modalities. Is treatment acceptable by the patient cohorts? Well, most heart failure interventions that we offer in terms of pharmacotherapy, cardiac rehab, even devices, are accepted by these patients. They want to feel better. They want to live longer. Is the natural history understood? Absolutely, this is a well understood condition. It's the pathophysiology and natural history is well characterized. Is there agreement on who to treat? Lots of trial data, lots of guidelines tell us who to treat, when to treat, and who not to treat. What about the cost of case finding? Well, I think the way I'd look at it is if we are finding this loss of cohort of patients, we're potentially reducing admissions to hospital long term and reducing healthcare burden, so potentially it is cost beneficial. And is it a continuous process? Again, certainly feasible using medical records, as I've shown. So just to summarize, hopefully I've demonstrated that a missed cohort of patients with heart failure and or LVSD in the community who are not under the care of conventional heart failure services are often undertreated with evidence-based treatments, and they require medical optimization or consideration of devices. And these patients can be readily identified using a simple screening approach. The concept of screening has not been widely studied or gained attention in heart failure, but heart failure is indeed suitable for a screening or case finding approach. And just to finish off, is it time for a rethink? Thanks very much.
Thank you, Dr. Khan. This is an amazing work, and it seems like you're starting to fill in some gap in the diagnosis of heart failure. Looking forward to hear more of you and your results. Moving to the next speakers, Dr. Elham Hedayati and Penila Gunther. Heart failure could be detected early high-risk groups. This includes people who have received cancer treatment. We will hear more about this from Dr. Elham Hedayati, Senior Consultant in Clinical Oncology, Associate Professor and Head of the Karolinska Center of Clinical Trials, and Pernilla Gunther, cancer survivor and heart failure advocate, as well as founder of Citizens Affairs and Focus Patient and former member of the Swedish Parliament. Thank you for being with us.
Thank you so much for this invitation. I have just a few minutes, so I will keep it very short. The title of today was Catching Heart Failure Early in High-Risk Groups. But before we come there, we need to understand what is cancer therapy-related cardiovascular toxicity and when does it actually occur among cancer patients. Well, it's actually, it can be a direct heart damage, and that can come directly during a treatment, or it can come later on after end of treatment. And it usually involves the heart muscle. It can also involve the coronary arteries or the valves or the conduction system, basically. But it also can involve the vascular system and cause hypertension. And it can also cause some coagulation disorders like thrombosis or extreme bleeding. And it's not only because of the cancer, it's usually because of the cancer therapy itself. So, and the risk of developing this cancer therapy related toxicity increases, of course, by age, and cardiovascular diseases increases generally by age. And also if there is a risk, or there is a hereditary in the family. Other comorbidities may also cause developing CTR, CVT, and it can be previous heart diseases, but it can also be kidney diseases. The treatment itself, the cancer treatment itself, can cause a toxicity. And for example, in the way back when we were having not the technology that we have today, left-sided radiotherapy, especially among breast cancer patients, it could actually cause a damage in the heart muscle or the coronary arteries. We also know that the given cumulative dose of different kind of toxic drugs, like for example anthracyclines, is also a risk of developing cardiovascular toxicity. And we have also these risk factors. They are common. They are actually very common among the cancer patients, and the reason for that is that many cancer patients, they have other diseases, because the most common age for having a cancer, developing a cancer, is around 60 and 65, both in men and women. And usually by that age, the patients have comorbidities like hypertension or diabetes. But unfortunately, the recent years, both diagnostic and also the treatment options within cancer has improved drastically. And this is actually causing that we have more cancer survivors. And you see here in this picture, they show that they predict that by 2040, we will have about 26 million cancer survivors, and the majority of them are above age of 65. And it's a very short description of the cancer therapy and the changing of the landscape that has actually increased the cardiovascular toxicity among our cancer patients. And you see from 1950s until millennium, we usually had the classical chemotherapy agents, and they were usually actually causing myocyte damage. And this usually comes maybe after couple of years after end of the treatment. But then in beginning of the millennium, we started having these targeted therapies, for example, trastuzumab, which is a quite common drug among breast cancer survivors, where there we know that these targeted therapies, they can cause a damage which is reversible. So as long as you have these therapies, there is an increased risk of cardiovascular toxicity, but as soon as you end them, then the risk is very little, almost none. But however, usually we give these drugs in combination with chemotherapeutic agents, so there is more risk for those patients actually. And then, as you know, from 2010-15, we have these immuno-oncological therapies, for example, in lung cancer or melanoma, There we can see that those actually cause an acute inflammatory disease, and it can also be a myocarditis, for example. And it's very, fortunately, it's very rare, but when it comes, it's really severe side effect. So very shortly, you can see the cancer treatment can cause different kinds of cardiovascular disease, but of course, the most important one and the most severe one is when there is a cardiomyopathy and a heart failure. And that is something that needs to be taken care of, and you hope it should actually be taken care of in a way that we should make a risk analysis of the patient before we start the treatment. So once again, the new guideline, they recommend that we risk stratify the patients before the start of the treatment. And if they are categorized as a low-risk patient for cardiovascular diseases in future, then they don't actually recommend any contact with cardiology in the beginning. However, a routine oncological follow-up should be done, but those patients with moderate risk, they should have a closer oncological follow-up, but also come to a cardiologist early, quite early. And in the very high and very risk patients, then the cardiologist should be involved from the beginning of the treatment. And of course, the follow-up and the treatment of the specific cardiovascular disease should be done by a cardiologist. So how do we avoid cardiovascular toxicity among these patients? Well, first of all, we should treat the risk factors. So the oncologists here, they have a major part to ask about these risk factors, and also maybe to take care of them and treat them. But those patients that are in need, high-risk patients, where the cardiologist usually maybe will start with a cardioprotection with different drugs. And the most important is actually really cooperation between cardiologists and oncologists, and a close monitoring of the patient. So that was my very short presentation. And I give the word back to you and to Pernilla.
Thank you, Elham. And I just think that what you just shown here is really important to know the history of the patient, the importance of really take care of the history and the treatments that this patient have been through before, or just to know also the history for the patient, him or herself. Because you can have had a treatment for many years ago and just don't think about it anymore, and just don't think to tell your new doctor what it's all about. And maybe it could be of great importance to know earlier treatments, of course, but also as a risk factor to know yourself and the risks maybe you are have been opposed to. So I think access to early diagnosis is really to have an engaged and knowledgeable primary care doctor or heart failure nurses, as we have in some places in Sweden, and to have an access that is not limited to just only a few hours per day. I know there is an example from a city, very small city in Sweden, when they have access for heart failure patients to call anytime to a heart failure nurse, and it has really reduced the need of care for these patients, because the worries is just like to have disease or diagnosis that is very severe. When you reduce people's worries, you can also treat them in another way. Calm patients is also always safe patients are always easier to deal with as well, as I'm representing the patients here today. So I think both to history, the present, and also to be able to look to the future for patients is very important to know what is happening. And that is also something that reduces the worries and can also help the treatment, whatever treatment you are having. Thank you.
Thank you. Thank you both for sharing your experiences with us. And it's important, especially from you, Pernilla, it's very important to know the experience of the persons themselves on this. Next, we will focus on heart failure management. Professor Silva Cardoso, Professor of Cardiology at Porto Medical School, will start with an overview of the opportunities for innovation in heart failure care with telemedicine.
Hello. It's a great pleasure to be here at this forum, and I'm going to address the issue of innovations in the management of heart failure patients. The vital journey of heart failure patient spreads through an outpatient setting, but also into an hospitalized setting when the patient is stable and when the patient is unstable. This is why the caregivers to an heart failure patient include primary care specialists and hospital specialists like cardiologists, internal medicine doctors, and other. And in the frontier between the two scenarios, there are transition points where nurses play a very important role. So this is why the care for an heart failure patient is multidisciplinary and integrated, and this is the standard of care and can be expanded by telemedicine. Telemedicine is the exchange of health information and or care instructions using a digital support to optimize care. The drivers for telemedicine implementation in heart failure include the high heart failure prevalence, the inherent hemodynamic instability of heart failure, and the need for patient empowerment. Also, other drivers include the organizational burden that heart failure represents and the high heart failure associated costs. Telemedicine is thus a complementary to in-person patient management. It's not a substitute, and it allows a more agile and frequent patient contacts. Telemedicine heart failure current solutions include teleconsultation, telemonitoring, telerehabilitation, shared electronic patient records, and teleconferencing. Teleconsultation allows patients' symptoms, vital signs, and blood test results assessment, and it allows a more agile patient management system, reducing organizational burden and while allowing more frequent patient contacts. It allows expeditious heart failure initiation, therapy, and titration, more frequent clinical monitoring of unstable patients, less frequent in-person appointments in the case of stable patients, and closer contact with patients under palliative care. Telemonitoring main purpose is early heart failure decompensations, detections, and treatment to avert hospitalizations. The methodology is a multi-parametric approach, and it can involve invasive and non-invasive monitoring and requires the patient adherence to a daily routine. Additional purposes include arrhythmia detection and patient education and empowerment. in order to promote therapy adherence. Telemonitoring added to usual care showed to be able to reduce all-cause and cardiac hospitalizations, to reduce length of stay, to reduce all-cause and cardiac mortality, and improve heart failure self-management. In the future, telemonitoring will include automatic data collection, the use of wearables, and the Internet of Things, making telemonitoring imperceptible for the patient. Telerehabilitation is heart failure cardiac rehabilitation at home with or without telemonitoring. It is an alternative or a complement to center-based cardiac rehabilitation. It showed to be safe, to improve functional capacity and quality of life, and to have the potential to be cost-effective. E-medical records may allow patient medical records automated data collection, thus enabling continuous heart failure registries, and also, very importantly, benchmarking among heart failure centers, a tool that showed to improve quality of care. Shared e-records and teleconferencing are multidisciplinary integrated care enhancers by allowing an agile communication among hospital-based and primary care heart failure specialists, and it allows also real-time clinical information sharing. Artificial intelligence-powered patient management will be certainly the future, but it will require high-quality data. Machine learning techniques allow to identify patterns within big data, thereby allowing to create specific models in order to continuously improve treatment and prognosis. The patient digital twin will be a common practice by using a patient's virtual representation built on patient's clinical data combined with registry-derived big data. It can be used to virtually test different therapeutic options effect, and it will lead to more personalized patient approach and treatment. The future will be an AI-powered telemedical multidisciplinary integrated care. This will be a new model of heart failure management, leading to a common and shared patient e-record, expanding on current multidisciplinary team approach towards precision medicine. There are some barriers to telemedicine in heart failure management, though. These include costs, reimbursement policy, regulatory constraints, technological barriers, and patient and caregivers adherence. So in conclusion, the present gold standard of multidisciplinary integrated care will evolve in the future to an AI-powered telemedical team, multidisciplinary integrated care team. Despite this, there are some barriers that must be overcome. But telemedicine will enhance heart failure multidisciplinary integrated care towards a personalized approach, and it will reshape heart failure care delivery systems by improving their efficacy and extending their scope. Thank you.
Thank you, Professor Cardoso. Hopefully we will all work together to overcome all the barriers for telemonitoring. Now we move on to hear about 3 promising case studies. The first one will be the PASSION heart failure study, an exciting doctor-at-home model presented by Dr. Lorena Hill, a heart failure nurse and senior lecturer at the Queen's University of Belfast. Welcome, Lorena.
Thank you, Caterina. It's a great pleasure to present at this summit, and it's lovely to follow Professor Sylvia. So hopefully I'm sort of reinforcing some things of what he said and adding some additional information as well. So I'm here today talking about a really innovative project that I've been involved in since 2018, and it's the Passion HF program, or Passion HF project. A bit of background, which we're all aware of. We have a rising global prevalence of heart failure, and really there's heterogeneity across Europe. In some places, it's getting very diverse in terms of massive numbers. In other cases, it's staying stable. And this comes at a large economic cost. There was a study done in 2012, which was 10 years ago, and it estimated that about $108 billion are spent per annum on heart failure, and 60% of this is attributed to direct costs, which would include your rehospitalizations. And we have within healthcare a growing awareness that we need to shift our approach from this one-size-fits-all approach, which we are all used to doing, to a more personalized and patient empowerment approach. So what did Passion HF aim to do? So its initial aim was to develop an integrated e-health product that will enable self-care, including the self-prescription of medications in patients with chronic heart failure. And the prototype of this e-health product is currently called Dr. Me. There's been a couple of name changes, but currently it's called Dr. Me. And how was this going to be achieved? More importantly, it would be more than just an add-on to standard care. This would be an alternative to standard care, but very complementary to the multidisciplinary team. It meant a formation across Europe of clinical technical partners. So clinical sites include Belfast, Dublin, Aachen and Maastricht are all involved in the project. The lead partner is Professor Brunner in Maastricht. Because this is an e-health project and e-health device development, 3 technology partners were brought on board, in addition to 1 research foundation. Initially, this meant a co-design involving key stakeholders. So the first work package within the study was a co-design, or basically speaking to key stakeholders, including patients, caregivers, GPs, and heart failure specialists. In addition to that, there was the development of the technology. And this was essentially a number of parts. First of all, algorithms were developed which would inform the titration of the medications. And these algorithms were informed by the International Heart Failure Guidelines, in addition to expert clinical practice. Also, drawing on the prototype was the requirement to have a centralized patient database. And this was a very important piece. And initially we all had databases within our own institutions. However, to actually centralize those databases and make them be able to transfer the information from that database into the eHealth prototype was extremely challenging. And hence we developed our own database called a Castor database. There was also a portion of AI modeling to inform this self-learning advisory system, in addition to serious gaming to ensure engagement with the patients. Within each country, there was the requirement for ethical and governance approval within each country, and also the importance of engaging our clinical champions to ensure that the project was viewed as an additive and as an advantage, and also to ensure whenever it came to the feasibility study, they'd be willing to engage in the project itself. So there's very much a lot of challenges, including country-specific healthcare system differences and differences in terms of regulatory arrangements. So what has our initial findings been so far? So far, we have completed a qualitative piece of work interviewing patients and caregivers. We interviewed 49 patients and 33 caregivers from across Europe within these 4 clinical sites. And we identified 4 themes: needs and expectations, perceived risk, trust and preferences regarding care processes. And this is just 2 quotes from a Netherlands male patient and a British male patient. First of all, in terms of advantage, the Netherlands or the Dutch male said, I'm out there, and when something happens, there's somebody who's watching over me and alerting or calling for help. That gives you confidence, then you have reassurance. Therefore, they were aware of this project, that it could give them a service which could be 24/7. The disadvantage of this is that all of a sudden you are moving from a doctor that was a real person to a more virtual device. Feasibility testing of Dr. Mayo, the prototype, is currently ongoing as a decision support system. We have over 400 patients recruited across Europe, and hopefully this decision support system will be ready for implementation after the Passion HF project finishes in December 2023. However, there's been a number of ongoing challenges, including technical challenges such as data transfer and security of that data, monitoring in terms of who monitors this, the data that's collected from these patients in terms of symptoms and blood pressure and weight, who does that, how frequently should it be done, and certainly there's an issue regarding funding in terms of continuation of this project. So looking to the future, our plans are to further develop a more autonomous Dr. Me that will be then prospectively tested in a randomized controlled trial. However, with additional very much areas of focus, including those patients who are over 75 years, those patients who have poor health literacy. We have to be aware that we need to encourage and promote a more responsive and integrated healthcare systems with transfer of data across primary and secondary interfaces, in addition to across other boundaries, at the same time preserving data and regulatory compliance. So thank you, and that's some hyperlinks to if you want to know more about the project.
Dr. Hill, thank you. Thank you so much for this excellent presentation. Now we will hear about the Healthcare at Home project in Ireland from the project manager, Dr. Aoife Cullen, and the nurse lead, Chiara Matthews. Thank you for joining.
Great, thank you. Can you see that? Yep. So thank you very much, firstly to the organisers for giving us the opportunity to speak today. My name is Aoife Cullen. I'm Program Manager for Heart Care at Home at Centric Health. Today I'm just going to give an overview of the Heart Care at Home programme, which is a remote monitoring programme currently taking place in Ireland. So just some background on Centric Health. Centric Health was established in 2005 and we're the largest provider of primary care services across the island of Ireland. It was established by Dr. Maurice Cox, who's an orthopaedic surgeon, and Dr. Ray Power, who's a GP. We provide both primary care services, specialist care service in areas such as dermatology and heart failure. We have a medical recruitment company called Locomotion, and we provide a company called Global Vision, which provides digital photography and grading services for our retinal screening programme nationally. We have over 70 GP practices and primary care centres across the island of Ireland, and we currently have just reopened sites in Germany and the Netherlands, looking after over 50,000 patients, which brings our total patient cohort to over 600,000 patients. The Heart Care at Home programme was launched in 2020. It is a collaboration between Centric Health and Roche Diagnostics. It originally launched as a clinical care programme, but it was then changed into a research programme and has been running as a research programme for the last 2 years. It's led by Dr. Donald Bailey, our Director of Clinical Innovation, Ciara Matthews, who is our clinical lead nurse, and myself, Aoife Cullen, who is the programme manager. So Heart Care at Home is a remote monitoring programme. It works very simply in that we provide patients with all the equipment they require to remotely monitor their heart failure symptoms at home. So they are asked to measure their weight, their blood pressure, and their heart rate twice weekly. This data is then transferred to a dedicated clinical team who all work remotely and are led by Kira, who monitor and assess that data in the background and try to identify any suggestions of deterioration or clinical changes. The team can then interact with the patients on those signs of deterioration and titrate their medications if required, or provide them with clinical advice to escalate to their GP or heart failure clinic. So we work with a company called Lucy, who are based in the Netherlands, and they provide our remote monitoring devices. We also provide patients with blood pressure monitors, weighing scales, and a smart device if they require it. We support all patients to download the Lucy app onto their device, so they can put this onto their own phone or smart device or one of ours. And then they're asked to measure their clinical blood pressure, heart rate, and weight twice weekly. They're also asked to complete a symptom checker and a mood score. We then have direct one-way messaging built into the app, so we can talk to patients at all times. And we recently added a photo instrument to the app as well, so patients can send us photographs of any clinical symptoms, such as leg swelling, or if required, if they have a new medication, they can send us a picture of that or a new prescription. This allows us to interact immediately with patients, so we can message them immediately, or we can provide a phone call or an email if required. We've kept the Lucy app quite simple, and it's very, very easy to use, and most of the patients can manage it quite well. So this is what our clinical caregivers see then on the Centric Health side. So data flows into the app and to the clinical team dashboard. Our program runs from 8:30 in the morning till 6 o'clock in the evening, so patients can view, or our clinical team will view data within those time points, and it runs throughout the year, so we don't take any breaks or holidays during the year. We have set parameters within the system which will alert the team if a patient's blood pressure, weight, or heart rate fall outside those. If their symptom checker changes, it will also alert the clinical team. If a patient mismeasuring one of the parameters that we have, it will alert our team that they've missed 3 measurements. Patients are allowed to take breaks on the program, so they can take scheduled breaks or holidays, and this has really improved our engagement in the program. We work within cardiologist approved protocols, so if a patient's measurements alert, the team will use these protocols to provide advice and guidance back. So as I said, we can titrate their diuretics directly, so we will do a 3-day titration with the patient, and then we'll monitor them closely for 14 days post-titration to make sure it has been successful. We always inform the GP directly of any advice given to the patient if there's any concerns or deteriorations, and our first point of contact is always with the patient's GP. And as I said, the clinical team work all year round. So I've got some very basic results, and the full results from this research study will be available towards the end of next year. We currently have 170 patients active on the programme. The majority of those patients have been on the programme for over a year. The age ranges from 35 up to 99 years, and I can say that 99-year-old inputs their own data into the app. We have 44% of the cohort are female. 83% of patients will input their data on the day requested. So our monitoring days are Mondays and Thursdays, and the majority of patients will input data on those days. They do get a reminder through the app if they miss a data point. We manage about 60% of titrations directly through the team, and so this is where we identify deteriorations and we advise the patient. So all the titrations that have occurred over the last 2 years, 60% have been managed by our team. Approximately 40% of cases require escalation back to a GP or a heart failure clinic, and this is in cases where patients are considered high risk or have chronic kidney disease, for example, and just require an extra level of monitoring or support. So we would escalate them back directly to their GP. We have estimated a reduction of approximately 70% in our hospitalisation rate. So this is a significant reduction in the hospitalisation rate of these patients. And overall, the results have been very promising to date. So I'm just going to run through very briefly some of the challenges and successes we've had with the programme, because there's lots of remote monitoring programmes happening at the moment. Recruitment has been one of our biggest challenges, and I suppose we started during COVID and we tried to recruit during COVID. So our primary care sector has been under huge stress and strain. And that's been one of the most challenging parts of the project for us, is to try and get patients onto the programme. We have found that meeting with the GPs face-to-face has been really helpful in increasing engagement. And now we do most of our recruitment through self-referral, so patients referring themselves to our social media channels. We've used media engagement, we've tried to do social media posts, and that has really improved recruitment as well. We've streamlined our referral process to make it as simple as possible for primary care sites to refer into the programme, and we've had huge engagement with many of the heart failure advocacy groups and charities across Ireland. The technology has been challenging at times, but if there is to be any potential benefit of COVID, as many of our patients are now much more digitally connected and aware. A lot of our older patients are well able to use the technology we're providing through the digital devices. All our team are digital champion trained, so this was additional training they underwent to work with older people to enable them to use new digital technology. We continuously update the Lucy app, and we've done huge enhancements with the app since we started the programme. And Lucy have been it's been a very positive engagement with them in order to improve the app itself. And as I said, patients can contact the team through the app itself, through video, phone, and we have a WhatsApp line as well. Integration across the health system is extremely challenging. We don't have electronic health records across our acute sector in Ireland. We do have electronic records in our primary care sector. From the very start of the study, we made it very clear that all engagement would be directly with the patient's GP, and that's what we try to do in the majority of cases. We can escalate to the hospital team if required, but the first point of communication is always the GP. And we use a secure encrypted email service for communication with GPs. And one of the other challenges is patient education. So during COVID, patients didn't have the same access to patient education as they would have outside of these times. So we have to be very sensitive, and the team have to be very aware when they're speaking to patients of the language that they use. Not all our patients are told directly that they've heart failure. Other phrases and words and terms for heart failure are used. So we just have to be very aware of that in our communication. And all our team members, all the clinical team, are trained in cardiac rehab. So we're re-emphasising the education patients are getting from their clinical team. And just some of the successes of the programme, I think it's important to highlight these. We have a less than 3% withdrawal rate, and as I said, the majority of patients are on the programme for over a year now. Patient engagement has been excellent, and with 83% of patients inputting their data when required. The feedback from patients has been excellent and extremely positive. And I suppose the support, comfort and security of knowing you have a clinical team at hand to answer any of your questions. The clinical team deal with a huge amount of clinical issues, not just heart failure. Our NPS score has been stable around 64. GP feedback has been very positive. Again, they value the support and knowledge of our clinical team and feedback that our team gives to them. We have had a significant reduction in GP visits required for these patients. Usually it's just a quick email or phone call between our team and the GP to escalate a case. Interestingly, the entire Heart Care at Home team was recruited remotely during the pandemic, and we have continued to work remotely throughout the last 2 years. This has meant that we've been able to recruit highly experienced and talented team members from across the island of Ireland to work on the programme. As I said, the research results have been extremely positive to date, and we expect to have very positive results to publish next year. And again, that we deal with, just to be aware, we deal with numerous additional non-heart failure related issues, and these are managed by the team, where they either are escalated back to a GP or to the patient's hospital team. We'll finish up there. If anyone has any questions or would like to know more about the programme, please feel free to email myself or the team directly, and we'd be more than happy to answer your questions.
Thank you. Dr. Pescos, she also has provided a recording about the priorities of innovation and technology health, including the development of new models of care delivery, boosting of diagnostic and digital tools, enhancing the potential of health data,
Good morning. My name is Cristina Vescos. I'm the Director of Innovation at EIT Health. I would like to thank the organization of the Heart Failure Policy Network for inviting me to give this talk prior to your discussions. I apologize for not being able to be there, but I hope you can enjoy this small presentation about opportunities and trends in innovation in health. Heart failure is a special topic for me because I've done many of my research topics around heart failure, and I think it's really crucial because it has two probably contradictions. One is definitely from the chronic disease is the one that touches most elderly population. And this is really a challenge when we talk about technology and innovation. But on the other hand, it's one of the areas where there's most potential for saving, especially in the area that you are discussing today, how to transfer diagnostic and caring capabilities towards the community and the home. Let me start talking a bit about EIT Health. For those of you who don't know, the institution is part of the European Institute of Innovation and Technology. The part of health was created in 2016, and we are part of the Pillar 3 Innovation in Europe of the Horizon program. Our mission is to tackle the health demographic change and well-being really by powering innovation and technology with the triple aim of better health for all, improve the sustainability of the healthcare systems, and improve the competitiveness of the European startups and industry. We are a network of more than 150 partners from academia, business, and research. And this combination is what we really think that can tackle the complexity of the health problem. So we need to put together academia, research, and business in what we call the knowledge triangle. Our network is distributed all around Europe with 8 regional innovation hubs and an InnoStars ecosystem also for the Eastern countries. We are working on a combined business model of European grants and other funding sources, and we are from this year, concentrating our efforts in 4 specific strategies that we are calling the flagships, and I'll come back to that a bit later in the presentation. The presentation of today is about the challenges and trends in the healthcare, and for that we need to look at this triangle that has 3 parts. First is generally to the challenges in general, probably coming from the trends in the population and in the workforce. The second is related to the demand side. So what are really our customers, our patients and citizens are looking for? And the third one is the scientific and technological supply trends, the technological push. If we see about the first part, the healthcare system, the biggest change is really with the elderly population and the rise of the chronic disease, but there are also other trends that you can all identify, the shift towards prevention and healthy living, the patient-centric approach, and also the challenges coming from the workforce in terms of shortfall of professionals, and also challenging the quality of the healthcare and the cost of the current situation. If you go to the demand side, there is a clear shift toward patients taking more ownership of their own treatments and becoming more digital savvy. I understand that, I mean, healthcare failure, as we commented before, it started in a very, in general, a very elderly population, but even them and even these patients have caregivers or have family members that are also these digitally mature and are looking for more solutions and more contact, more response from the healthcare systems. We see definitely trends also in terms of the importance of mental health and how we are integrating and communicating between healthcare and the patients themselves. With regards to the supply side, I don't want to go into all the details of the slide, but definitely pay attention on the data. It's all about data, and it's not only the data in itself, but what to do with it, the area of artificial intelligence, digital therapeutics, and how to incorporate real-world data into the evidence of and the treatment of the different patients, more digital solutions, especially telemedicine after the pandemic, and incorporation of more technologies like robotics and wearables. With all that, what we can see is from EIT Health, we wanted to concentrate on big areas that can really mobilize all our community, from business research to education and healthcare. And these 4 areas are: first, new models of deliver healthcare. And where we are looking here is not for, again, another technology push, but looking at the many technologies that we have mature. The real innovation that we are lacking at the moment is in the area of service and business innovation. We need really to transform the healthcare systems towards value-based models. The second flagship is related to the uptake of digital medical devices, especially on the area, I mean, what is related to patient management. And so these in general are low-risk technologies that are already available for many other sectors, but in the healthcare, we are lacking this fast implementation, testing facilities, and fast incorporation into the reimbursement models. The third flagship is related to the reindustrialization of Europe, and we are supporting deployment of the important project of common European interest in health, both in the area of biotechnology, vaccines, and advanced therapies, but also in the second wave in digital health. And the fourth flagship is all around the supporting of the European health data space, and the role that we are taking at EIT Health is not in the infrastructure, but really in optimizing the potential of this data that we have spread all around Europe in different formats and in different places. If we look at the portfolio of EIT Health in the past, and we were active, as we said, since 2016, there are different diseases that have been specifically addressed by our portfolio of more than 150 million euros in the last 6 years. And we can see that cardiovascular had a very important role. And in the future, looking at the projects that have been already approved for the next 2 years, definitely cardiovascular is the biggest area. I would like to address just 3 examples of our portfolio. In EuroHeart is a project that is creating a digital 3D twin image of the heart, so that is a tool to improve the diagnostic and the personalized treatment for the surgery of the cardiovascular patients. The second project is Corify, the startup. The project is called SafeCore, and it's also a diagnostic tool to improve the detection of arrhythmias, and it's also trying to transfer this diagnostic capability from academic hospitals to lower levels of healthcare delivery. The third project is called Better at Home, and it was a multidisciplinary project. So it's covering the management of chronic patients in different therapeutic areas, but it's about exactly the topic of today: how we can translate the management of these patients out of the hospital. So it's a project of hospital at home, and it had really fantastic results during the pandemic, where really the direct interaction between the hospital and patient was impossible. I don't want to close without talking about education. That is also one of our pillars, because all this healthcare transformation that we are discussing cannot happen if we don't have the right workforce. So there is a special need for upskilling and reskilling the healthcare professionals. And we need to educate our staff not only in entrepreneurship and in digital skills and in digital competencies, but it's also about the importance of the healthcare transformation and how these innovations are going to affect their daily life. And last but not least, I would like to close with this global trend about the synergies. One thing that we have realized after many years of technology and innovation, I think globally, but especially in Europe, is that we cannot do the thing alone. So coming from the Sustainable Development Goals of the UN, and especially those related to health, how the European Commission has set up the priorities for the next years until 2024, where there is a combination of policies that are affecting our health, but it has other components like the digital age, the Green Deal, the importance of the workforce and the competitiveness of the European industry, but taking in consideration our values, way of life and democracy. And EIT has these four flagships also to represent our main goals, as we have said, that is the better health for the European citizens, the sustainability of the healthcare systems, and improving the competitiveness of the European economy. So I hope I have given you enough food for thought for the next session. So thank you very much. And you have here my contact details if you need to reach me. I'll be happy to hear from you. Thank you very much.
Both presentation, along with the others, will be available at the event platform, so everybody can watch them later on. I would like to start with the questions and the questions that the viewers have sent us first. And I will start with Dr. Khan. Dr. Khan, are you here with us?
Yep. Hi there.
So I have a question for you. How did you cope with the increase of the echo request? And was this and did you, as primary care setting, also were able to watch all these patients as well?
It's a great question. So I've done this. I've run this service out of two hospitals personally. The first hospital was a big DGH in a very deprived area, and then more recently at Heart and Chest, which is a large tertiary centre. And I think the most important thing you have to acknowledge is you can't just do this by yourself. You have to engage all stakeholders. So that is other physicians that are going to be taking part, your heart failure team, community heart failure team, specialist nurses, of course, the echo department. At Liverpool Heart and Chest, we have to involve the device department. So there's lots of people that need to be on board with this, and potentially you are going to put pressure on services like an echo department. Now, the data I presented so far, I think, bear in mind that's 4 years worth of data. I think I presented 230 GP practices. I think 1,500 patients were seen. That's over 4 years and over 20 hospitals. So at the moment, although it would put pressure on services, there's not anything significantly that's been reported. In Liverpool, in particular, we're looking to run this out across the region in a more of a sort of systematic manner. And one of the things that we will look at is maybe novel ways of involving other centres, how we use our resources like echo more appropriately. But I would just make the point that although it's going to put a burden on services like echo, like your local heart failure services, I think that's going to be balanced across the benefits that patients are going to get. If we find this missed cohort of heart failure patients, we're going to be able to optimize them and reduce their chances of an admission long term. That's going to ease the burden on hospital services, and also we're helping out in primary care. We're helping with their caseload, supporting them, allowing them to optimize patients more efficiently, and again potentially preventing increased visits by heart failure patients to primary care.
Okay, great. I also have a question for you. Most challenging in the primary care setting is also the patients with preserved ejection fraction. I think this is one of the biggest challenges nowadays with the aging population of early screening and so on. So do you think that the way that you're trying to organize the primary health care settings are going to will contribute to the early screening of this population as well?
Yeah, so absolutely. I mean, HEF patients, we all know, are extremely difficult to treat, multiple comorbidities. And one of the things we're looking to do is translate what we've done with HEF-REF patients and take it forward into a HEF-PEF population. I think it's not going to be straightforward, and I think we'll identify a huge amount of patients. But what we've done effectively is case finding. It's not complicated in any manner, but we can apply the same principles in the HEF-REF population, the HEF-PEF population, and we now, of course, have newer therapies available to us for these sorts of patients, and it's something we're looking to do locally in Liverpool, and then again, like we've done with the PCHF service, rollout after that.
Great, thank you. So moving to Dr. Colin, 70% reduction of hospitalization is a promising impact. How do you measure this? Do you have much controls?
So we have done it in a number of ways. We have national data of hospitalization rates of patients each year that we use, and we're using the patient cohort as a control against themselves. So we measure in the years before they come onto the remote monitoring program how many times they've been hospitalized. So we're using a combination of data, both national and our own data, to measure this.
What I would like to ask you and especially Chiara, who's closer to patients, Dr. Hill, because we heard already that one of the barriers for telemonitoring and telehealth is patients' adherence. So what I would like to know, and I think other health professionals as well, but also patients themselves, is patients' perspective and experience through these all innovative strategies using technology that you already show. So I think I will start with you, Dr. Hill, and then move to Chiara.
Yeah, so thank you, Katerina. That's a really good point. And initially from a patient perspective in terms of just working in clinical practice, it was not surprising to hear patients report that they preferred to see a real person, that they liked interacting with technology, they saw the benefits of technology, but there was nothing as reassurance as walking into a consultation with somebody that they knew their history and knew exactly where they'd been and what treatments they'd tried. However, they also had a growing awareness that that was no longer becoming possible. And I think the main contributing factor to that was the increasing space and time between each consultation was getting longer and longer. Initially, it was every week, then it was every 6 months. And also during the COVID pandemic, whenever they no longer could see the patient or their consultant or heart failure nurse face-to-face. So they have a growing awareness of the importance of technology. They're very much willing to engage in technology. In the cohort that we have so far of over 400 patients, they do engage and they're very willing to engage in it. And they're getting, as they continue to use the technology, are getting more familiar and more comfortable. So we look forward to getting our feasibility and acceptability results at the end of hopefully next year. But certainly I do feel as if there's a greater interest in this move towards getting some support somewhere if they can't see their face-to-face consult or heart failure nurse.
I would also add to what Dr. Hill said. I mean, the pandemic was forced everybody to get more involved with technology. So it was like a test drive. It was like going into a study without even trying it. Chiara, what do you say about that?
Yeah, it's similar to what Dr. Hill had said. I suppose our program started during COVID, And I do think a lot of our patients were very thankful to have a program whereby they could access a nurse kind of at the touch of their fingertips. You know, they put in their readings, those readings are received, and if a patient sends in a message within a couple of hours, they were getting a phone back from our nurse. And I suppose, like what Aoife had said in her presentation, we wouldn't just deal with heart failure, we got questions in relation to everything and anything, and we were able to, I suppose, triage the patient to the appropriate person during those times. So I think our patients really appreciated that, and as we've come out of COVID, they still appreciate that. GP practices in Ireland, and I'm sure all over the place, are just so busy that patients could spend hours trying to get a phone call to get an appointment, and that appointment mightn't come for a week or two. So I know from our patients and the feedback they give, they love having someone at the end of a line that they can ask for advice and can be kind of pointed in the right direction as to where to go if they need help. Similarly, I suppose our patients range, like what Aoife had said, up one lady is 99 and she's really a whiz at using the app. We'd get a message from her a couple of times a week. I really think she even sees it nearly as a social outlet for her as well. And similarly, our younger population really appreciate it because it kind of fits in with their lifestyle. They just check their readings in the morning, pop it into the app, and off they go and go about their daily business. They know if they don't hear anything back, everything is fine. Likewise, if there's a problem, we're able to get them on the phone. I think as well, it kind of promotes good lifestyle habits earlier on in their diagnosis. You know, those guys are in their 30s or 40s, they're being more accountable to themselves, keeping an eye on their weight, monitoring their symptoms, and I suppose how they are in relation to their heart failure. So I suppose each patient is different, and it's just by keeping track of their symptoms twice a week, they know what's usual or unusual for them. We do, every time we have a phone call, promote good lifestyle habits with people. So, you know, monitoring their alcohol intake, exercise is a big thing. And I suppose what we have found over the course of COVID as well is a lot of cardiac rehab programs were put on hold or have gone virtually, or a lot of people have kind of missed out. So just, I suppose, being able to direct people where to go and what to do in relation to certain things. So yeah, patients, I think, really enjoy the program. Obviously, it's not for everyone, but definitely for the most part, our patients really appreciate it and have adapted really well to the digital side.
Right, thank you. Mrs. Gunther, I think what you think and feel is more important to hear right now. Do you think all this that we've seen today is possible? Shall we move on with technology and contact with you more and more regularly? So tell us about it.
Thank you. I do have all the solutions. No, but I do think that we need to think in I mean, patients are different. We are all different, and we have different abilities to adapt new things, new innovations. But I do think that nearly everyone nowadays have got a smartphone, and I do think that if we just can, you know, in a way, tell people that there are good things with technology. There are good things to be able to in a way treat yourself. I mean, self-monitoring, and if we really aim for an equal healthcare, we should use these tools really everywhere to make people be more involved. Patients of all kinds can be more involved by using these tools. I mean, not the least, I see in the northern Sweden, in Lapland, they have a great success with digital tools for patients. So I do think that when you present things in a good way and really tell them how useful it will be, you can be of any age. Really, it's not about that. It's how you are as a person and what use you can think you will gain from using these new tools. And I do welcome any innovation to improve the situation and empowerment for patients.
Thank you so much. This is so encouraging for us all. And Mrs. Gunther said something very important: equal health for everybody. And I'm going to Dr. Trom and Professor Cardoso. I mean, other obstacle are the resources, the costs that they are going up all the time. So how is it possible to move and change the healthcare setting across Europe to have equal possibilities for our countries and for all patients with heart failure? I will start with Dr. Trom and then Professor Cardoso.
Well, thank you so much. I think it's an excellent question. I think it's also one of the key issues that we're facing in scaling and sustaining some of these technologies. I think so generally, a lot of these interventions, I think in the long term, by preventing hospitalization. So for example, the example that Ms. Gunther gave, right, having a 24-hour nurse available that you can contact, right? Ultimately, if you can keep people out of hospital, in the long run, it can be cost effective. And the key thing is to show this. It's not just to talk about it, but to provide evidence to show that this actually works. It keeps people out of hospital. It's actually cheaper in the long run, and it keeps people healthier. And I think that's one of the key issues in getting this to market and getting payers to actually fork out the money to support this. The other part is when you have new models of care, right, where we do something that's not been done before. But again, then we have the exact same issue, right? If you want somebody to pay for it, you need to just simply show that it's cost effective, but that requires clear pathways for health technology assessment that address some of these technologies. So I think, to me, that's one of the key solutions for this.
Professor?
I couldn't agree more with Dr. Trump. It is very important to show to the healthcare decisors that heart failure is a major cause of hospitalization. In Europe and in the United States, it is the leading cause of hospitalization above 65. And that the costs of heart failure are mainly related with hospitalizations. This is key. Hospitalizations represent more than 50% of the costs with heart failure. So if you have an expensive disease and you know the cause of expenditure, the main cause, which is hospitalizations, and if you have technological means that can early detect congestion, which is the main cause of hospitalization, fluid imbalance, and then you may act early and avoid hospitalizations. This is, I think, the main message to pass to decisors. We have a tool that can be cost effective, certainly, but even cost saving if we can use it. And this is very important. The costs of heart failure surmount those of cancer. This is a very important disease. So there is a means. You have to invest, but at the end of the day, you will get your money back.
And I will continue with what Professor Di Somma has written as a specialist in the emergency. It will allow earlier patient discharge from the emergency department and ward as well, including them to telemonitoring, reducing emergency overcrowding and more bed available in cardiology ward. This is what they are trying to do in Italy. Hopefully this will be more global and we will gain more resources for moving and changing the healthcare settings. I feel what we need to do more is what we are doing today with the Heart Failure Policy Network is stay together, collaborate together, and make a stronger voice for tackling and managing heart failure and supporting patients with heart failure. Hopefully, we've learned from pandemic that this vulnerable population is crucial to find ways for a more continuously follow-ups. And this is how I will close this session. I would like to thank you all for contributing for this session, showing us what you're doing, which is great. Please continue doing that and also showing it to us. I'm thanking all the viewers and like to remind you that there are more 2 sessions to come the next 2 Wednesdays, touching on the topics of inequalities and person-centered care. So take care until next Wednesday and see you. Bye. Thank you.